Everybody, my name's Ian Beckley. I'm one of the urology consultants from Pinderfields. It's my co-chair Angela Burney from Portsmouth and soon to be joining Susie Venn in Wetton Sussex Hospital. This is the update section. We've got a couple of talks from the executive committee. The first one's by Sheila Reid on the new trainee curriculum, and the second is from Richard Parkinson from Nottingham. He's going to be talking about specialist unit recognition and commissioning. We'll take a couple of minutes for questions after those two talks, and then Maureen Paxad's going to give a talk on the growing burden of the anticholinergic burden. So, over to you, Sheila.
Right, good morning. I am talking to you about two things this morning. NICE updates, that's everything that's relevant to the section. And then I'm just going to talk to you a little bit at the end about the new curriculum. So, as regarding NICE, most of the things we talk about when we talk about NICE, we talk about the clinical guidelines, but there's also the other bits, the technology appraisal, interventional procedures, medical technology and quality standards, all of which have come out with some guidelines which are relative to us. The four clinical guidelines that are worth discussing for this section are probably the most important: the urinary incontinence in women, CG171, particularly in light of the talk we had this morning from Mark Slack. The urinary incontinence in neurological disease, that's CG148, that came out in August 2012. There haven't been any updates on that, so I'm not going to say anything further about that. Lower urinary tract symptoms in men, CG97, there has been updates in that, which I'll talk about. And the last one, the bedwetting in the under-19s, came out in October 2011, and there's been no updates in that. I also just wanted to mention the three neurological clinical guidelines: multiple sclerosis from 2014, Parkinson's disease from 2006, and the recently published spinal injuries guidelines from 2016. Unfortunately, these are all really light in the urological aspects, and they say nothing new, just much to my disgust. But what they do is they do signpost you to the CG148 guideline, that is the urinary incontinence in neurological disease. So the urinary incontinence in women, that's guideline CG171, that was published in September 2013, and it underwent a review and update in November 2015. And essentially what they said was that there was no new evidence for them to change any of the recommendations, with a big except. And not surprisingly, they have said that section 1.1, which is the surgical approaches to stress incontinence, needs an update. Now, that was supposed to have come out in June 2016, but unless I have missed something, it hasn't actually come out, and I did check it last night. This has come out of the NHS England MESH working group with the concerns that they've raised. So specifically, what the MESH working group have asked NICE to do is to produce a clinical guideline describing the care for women with pelvic organ prolapse, and they've asked NICE to put it into the CG171 guideline. They've asked them to review the current clinical guidelines for urinary incontinence and review the complications arising from surgery for stress incontinence, pelvic organ prolapse, with a comprehensive list of possible complications from mesh devices. So that's going to be very long. And then women's experience with the procedure were the main considerations in developing the recommendation. Right, lower urinary tract symptoms in men. NICE guideline CG97, published in May 2010, and again, it's undergone a full review in 2014. And in 2014, they said that there wasn't anything new that would advise change of the guidelines. However, in June 2015, there was an update saying don't offer PDE5 inhibitors solely for the purpose of treating lower urinary tract symptoms. And laterally, just came out last week, the green light laser update has come out. So regarding green light laser, as I said, that just came out in June 2016, that was last week, guideline MTG 29, and it supports the use of green light laser in non-high risk patients it says it's just as effective in these patients as TURP and can be used as a day case. However, it does not recommend it. It says there's currently insufficient evidence to recommend it for high-risk patients, which includes rather a lot of the patients we deal with. Those are those at increased risk of bleeding, those with larger prostates, or those in retention. There has been a NICE technology appraisal guidance, Mirabegron TA290 in June 2013, saying it's suitable to offer it. And then there are 4 interventional procedural guidelines. Sacral nerve stimulation for retention came out in November 2015, that there is evidence for its use. As I'm sure you know, its use in detrusor overactivity is already in the guidelines for both the female and male lower urinary tract symptoms. PTNS, they've approved that in 2010. And then I went back 10 years. These are the other 2 in the last 10 years. As you can see, the suburethral short tape was never approved by NICE, but the biological slings were. Right, just 2 things about the NICE quality standards, because there's been 2 fairly recent updates. I didn't really know what these were, so I looked it up. The NICE quality standards describe high priority areas for quality improvement in a defined care or service area. And there's 2. The first one is on urinary incontinence, came out in January 2015. There's nothing really mind-blowing about this. It does say that you should examine your patient, and the various things I have up on the screen. Useful things, probably, that mixed incontinence should go to an MDT before surgery or invasive treatment. So fairly common sense. Urinary tract infection in adults, quality standard document came out in June 2015. This probably is a little bit more useful in that it gives some very sensible advice about antibiotic management. I thought particularly, do not prescribe antibiotics for asymptomatic bacteria in non-pregnant women or catheterized patients, and don't prescribe prophylactic antibiotic for adults with catheters unless there's a history of recurrent or severe urinary tract infection, and a call for an update for the recurrent urinary tract infections. Right, that's all I'm going to say about NICE. Just to talk to you about the urology curriculum, I'm not going to go into it in great detail, and I actually have a copy of it if somebody wants to come and talk to me about it afterwards. But the urology curriculum, I'm specifically talking about what we've done with the FNUU module. So the urology curriculum as it stands now has 13 modules. So as you can see there, 1 and 2 are stones in upper tract, 3 to 7 are cancer, 9 to 11 is andrology, 12 is peds, and 13 is transplant. But the module 8 is now the FNUU module, and that's a merged module. So essentially what we've done is we've brought together all the aspects of the FNU curriculum and put them in one module. And the object of the module is to develop advanced skills in the assessment and treatment of men and women with urinary and genital tract dysfunction, including that arising as a consequence of neurological disease, and to develop advanced skills in lower urinary tract reconstruction. There's 12 subsections. And the reason we put these all together was, firstly, a lot of this sort of objectives and clinical science behind it was very similar. And secondly, and probably most importantly, we don't feel you should have one bit without the other. So the bits are management of continence problems in elderly and cognitively impaired, urinary frequency, urgency, urge incontinence, bladder and pelvic pain, stress urinary incontinence in men and women. So we're trying to introduce the fact that we don't just look after incontinence in women, it's about men as well. Mixed urinary incontinence, which is a new section, female retention, genital urinary prolapse, urinary fistula, urethral diverticulum, defecatory disorders, reconstruction of the bladder and ureter, and neurourology. You'll note that urethral reconstruction is not in this module. It was initially, but we were asked to take it out because the andrologist didn't want it to be in our module, so it's now a module by itself in one of the later sections. And that's all I'm going to say about the curriculum. So if there's any questions, we'll take them at the end. So thank you very much.
Good morning. So I get to talk about commissioning again. Right. Do I just press something? Right. NHS England has had a bit of a rethink on clinical reference groups. You remember specialised commissioning was defined by NHS England based on a whole list of things. It went through a whole list of stuff that we do, and it decided that some of it was specialised. Put it in a list, and if it was on the list, it's specialised commissioning, and that gets commissioned nationally, and everything else is locally commissioned. So it's not how special it is or how complicated it is, it's just whether it's on the list. Specialised commissioning got discussed with these clinical reference groups, which was basically some clinicians and some bods from NHS England to try and create some policies to make sense of it all. So over the last few years, we've had a whole load of nice meetings, and we've talked about it, we've come up with policies, we've come up with ideas about how you might define how specialised services should be delivered. We've talked about what a specialised unit might be and how it might be arranged and what sort of services that will provide for the patients. And this we ended up about 12 months ago with two policies, one on prolapse and one on recurrent incontinence. And after a lot of debate, we've now abandoned those because the CRG met and it was decided that nobody could really agree on how these should be enforced and how they should be policed. So actually now, most of the current clinical reference groups have actually been disbanded. They're now trying to create a smaller number of clinical reference groups with a smaller number of people on them, and they're currently being advertised and reformed. So that's where we are. So if anyone's interested in doing it, they can apply. I won't be. So incontinence was previously under the gynecology CRG, and it was mostly focused on stress urinary incontinence. Quite where it's going to fit now, it'll probably still be in that gynae bit, but it may also sort of maybe a little bit of in the urology one as well, which previously was mostly focused on cancer. So as I've said, there was a bit of a lack of buy-in from various parties, particularly BAUS16 actually, because and not unreasonably, they were questioning how we introduce this concept of managing recurrent and primary incontinence in completely different centres, and how that might impact on how the service is delivered. So that's all out of the window. BAUS16 continue to accredit units, and there's a process of BAUS16 accreditation, but this is nothing to do with specialised services or having a specialised unit. This is just about general urogynecology provision. BAUS has been looking at some form of accreditation or recognition, and the wording of this is sort of slightly nuanced. But this is something that we're still working on. We're trying to work out what accreditation or recognition might actually mean, and what it means in terms of commissioning and how we would organise services. So there's still nothing agreed on that. So, moving on, the one thing that did come out of the last few years was we actually ended up with a policy on sacral neuromodulation, which was a good thing because as of about a few years ago, they just put the kibosh on all neuromodulation for OAB, which you'll all be aware of. So just to clarify, sacral neuromodulation done for Fowler's syndrome, i.e. Avoiding dysfunction, is not specialised, and this comes back to it's not on the list, so it's not specialised, and it's commissioned locally, so your local CCGs will tell you whether you can do that or not. And you have to negotiate a local or regional policy if you want to do that, and you'll need a business case and everything else, but you should be able to do it. So neuromodulation for OAB and urgent incontinence is a different matter. That's commissioned through specialised commissioning. It doesn't involve the local commissioners. So the local commissioners and the CCGs shouldn't be directly involved in this. However, NHS England have area teams. So each of your areas, your regions, will have an area team for specialised commissioning. And the funding for SNM that's done for OAB goes through those teams. Now, in the past that was done through an individual funding request, which was invariably rejected, but now there's a policy. The idea is if you do an individual funding request, it should be accepted. And in fact, there should be a system of what they call prior approval, which basically means you tell them that you're going to do it, and they just automatically say, yes, you're allowed to do it. And we were led to believe that that would be a very straightforward process. There was even the Blue Tech online system. This is a system that's used for funding high-cost drugs for cancer and things. And the idea was we were going to use Blue Tech as a way of getting this individual funding request through for SNM. And the bottom line is, in theory, it works. And for me personally, it works because I was sort of one of the test centres for doing it. But those of you in the audience who've tried to replicate it locally will know it doesn't always work that way. And the reason is because the NHS England area teams have decided that they can say, okay, well, yes, we do have to sort of approve this, but we're not going to approve it in your hospital because it's commissioned elsewhere. You can go to UCL, for example, or somewhere else to do it. And that's basically exacerbated this postcode lottery that we still have now for neuromodulation. So what we came up with, the plan was we came up with this little sort of standard email that you could perhaps produce where you'd write an email to your local team saying, such and such a patient is going to have this treatment. They meet the commissioning criteria, and you'd list the commissioning criteria you have to meet, and you'd say specifically that they meet these criteria. So, I mean, I won't read it through it, but basically a whole lot of things about having urodynamics and discussing it in an MDT. And even the head of the senior program director for this, Anthony Prudhoe, said he'd have quite a bit of his name on this, and the area teams could clarify it with him if they had any objections. However, as we've said, it's still not happening. I've emailed these guys periodically, about once a month, saying, well, where are we with Blue Tech, and what's happening with this policy, and why aren't we doing it? And they just don't reply. And I sent out an email last week to Anthony Prudhoe and to some of the others, sort of outlining our concerns. And I mean, those of you who know me will know that I'm notoriously quietly spoken on subjects about which I have an opinion. And so this was one of those quietly worded emails, but they've still not replied. And I think we do need to have a bit of a think as a group about how we escalate this, because it's clear that not escalating will probably lead to a continuation of the status quo, and many of you then not being able to perform a procedure which is not particularly difficult to perform and which you're all capable of doing. So that's basically all I've got to say on the subject. I suppose I'd be interested to know what everybody thinks about how this ought to be dealt with. So hands up if you have tried to get funding for neuromodulation for OAB, and you've okay, and hands up, keep your hand up if you've been successful. Okay, hands up if you've not been successful then. Okay, so actually quite a lot of people. I think a lot of the people who are doing it were people who've been doing it for a long while, aren't they? And where the commissioners are kind of used to just getting a whole lot of patients coming through. It's the ones who are trying to set it up as or trying to reintroduce it, isn't it?
So what would you like us to do? I mean, because it seems like most people who've asked, there are a few pockets of not getting it through. What would you like FMU to do for you? I mean, should we write to the health minister or?
Tamsin, I think it needs to go through the BAUS and it needs to go through the President. Because that's going to be the strongest drive.
So who does it need to go to?
Well, it's an NHS England thing, isn't it? So, I mean, the start.
But you have to go to one above, the person that he's not talking to you.
Oh yeah, but sort of Simon Stevens, I suppose, is NHS England medical director, isn't he?
Well, there's one below who's in charge of specialist commissioning, isn't it? Is it Palmer? Jamie
Okay.
Palmer. I mean, in theory, it should be Jamie Palmer, who's the clinical lead for all of us.
That is the problem. We do
whoever it is, Anthony Crusoe or Jamie Palmer.
Shall I invite it, not you, as you decide?
Well, I think it's often, I mean, often when you're doing these things, it's very easy for them to reject things by email or to not respond. But if you sit them in a room and you present them with, here's a policy that you've come up with, why can't we do it? It's much more difficult for them to wriggle out of it.
The other issue is the original document that the Commission predicted 25 neuromodulators for OAD, the whole of England, per year. Yeah? So if we do raise this, we may lose all of it.
To be fair, that's not quite true. They modelled it on 25. They just did that as a, if there were 25, how much would 25 cost? But I mean, which was foolish, but they were informed that it would be 10 times that.
But Rich, we submitted documents, because I wrote them, saying 3,000.
Absolutely.
They're all in numbers.
They do.
It's not like
So what would people like us to do? Stay as we are, get everyone's opinion on another survey monkey, invite the man to come and see us, or write to Mike Palmer.
But Tamsin, the problem at the moment is there is a significant proportion of us that are just not moving forward in terms of getting the service to people locally. And Richard knows, I've been going around the circle and I've been keeping Richard in with the emails, but unless we move forward, we are not going to know where we are.
No.
Because the other problem is that the local groups don't know what's happening either, do they?
No.
That's part of the problem. Local commissioning groups, they are totally confused by what's happening.
So I think actually what I'll do is we'll send out an email survey to FNU members and say, would you like us to do it from A, B or C, and then we'll act on the majority vote. Yeah? Hopefully it's not Brexit.
Do we have any questions for Sheila? Or any more questions for Richard? No? Okay.